in listen-only mode.
Hello, everybody. It's John Muscaderi from the Canadian Frailty Network. Welcome to today's webinar. Today's webinar is on the ASILA case simulation prototypes on cognitive physical outcomes of frail seniors in nursing homes. We are excited to have Veronique Buscart, who is going to be presenting, and I will present her in more detail shortly. This is a series of webinars that showcases Canadian Frailty Network supported research on frailty and late life issues. We are scheduled to conduct over 20 webinars in 2016 and are planning up webinars for 2017. Although in the past we've highlighted research that's sponsored by Canadian Frailty Network or knowledge mobilization efforts. If anybody has any suggestions for webinars to be conducted in the future as we conduct our program, as we built in our programming, please let us know, and we'd be happy to consider the suggestions. And as always, the webinar and the slides are posted on the Canadian Frailty Network website, and you can find all the webinars that we have done in the past. They are a rich resource for information on frailty, so please feel free to seek out the webinars at your leisure. Just as an update of where we are, so at Canadian Frailty Network, we're just in the midst of adjudicating our summer student awards. Some of you may have applied to them. We've been able to double the number of awards to 20, so we will be selecting 20 students to sponsor over the summer months, and we will be announcing this in early April. Our new one-year fellowship is announced and it's posted to the CFN website, so please feel free to look at the website for that. And we are launching the ACE Collaborative, which aims to improve the care of the elderly, presenting to acute care hospitals across Canada. 18 hospitals have been selected across the country, and actually one of them is from Iceland, so 17 from across the country, one internationally. And all the funded teams will be announced at an announcement at the end of next week. The format for these webinars is that we do have a question and answer session. It usually follows the presentation, and we would ask you to submit your questions online during the presentation using the chat function. At the end of the webinar, we will answer as many questions as the time permits. As I said before, the webinar is recorded and will be available for viewing online within a couple of days following this webinar. So without further ado, I'd like to present our Veronique Buscart today, who's going to present on the ASILA case simulation prototype. Veronique completed her doctoral work at the University of Toronto on nurse-patient relationships and did a postdoctoral fellowship at the Toronto Rehabilitation Institute. She is the CIA Chair, Schlegel Research Chair in Seniors Care at the University of Waterloo and Conestoga College, and Assistant Clinical Professor in the School of Nursing at McMaster University. She is an adjunct professor at the University of Waterloo, and without further ado, I'd like to turn over the presentation to Veronique, and welcome Veronique, and thank you for presenting today.
Thank you, John. And good afternoon, everyone. Happy to present today to you on the work that we've conducted with a group of researchers, and I thereby would like to acknowledge my co-investigators, which are Dr. George Heckman, Dr. John Hurtis, and our HQP on this project was Michelle Heyer. So acknowledging the funding we've received from the Canadian Frailty Network in a Catalyst grant in 2013-2014, and I also received salary support from CIHR under the Community Innovation Program Chairs Programs for Colleges. So today I would like to present to you the ASILA program, or the Applied, Simulated and Integrated Learning approach, which is a new way of helping people within long-term care settings gain some new knowledge. Then also I want to talk a little bit about the perceptions of unregulated care staff about their role in complex care management for these residents. And then I want to discuss a bit about the importance of each of these team members in actual monitoring, assessing, treating, and following symptoms of chronic disease. So we'll have the next hour for us and, to do this, and I'll spend about 30 to 40 minutes talking about this. Sorry. So what do we have right now? Well, I think most of you on this webinar are very aware of the changing dynamics and the changing population within long-term care. But what we see is that there is a very fast increasing need for care for seniors, and those people that are in our long-term care settings across Canada have really increased in their complexity. We know that residents that come in these long-term care environments are more sick, they are more frail, and they often don't stay as long in long-term care as they did in previous years. And so obviously that creates additional pressure on the care capacity of these organizations, and especially on the workers. So people working in long-term care environment are unregulated care providers. In Ontario, they're called personal support workers. In other provinces or regions, they're called care workers or resident care assistants. And for the ease of this presentation, I'll refer to them as unregulated care providers. But we know that about 85% of care in long-term care environments are delivered by these unregulated healthcare providers. When we look at the gerontology content in healthcare education across Canada, a full review of all nursing curriculum, social work curriculum, and medical curriculum has indicated that there is not a lot of geriatric content in those programs, and especially nursing performs at a very low standard, and there is quite a lot of BSCNs that graduate without any content or knowledge in geriatrics. And so that is the same for our unregulated care provider, and that obviously leads to limited knowledge and training for these people working in long-term care environments. As a result, when these staff are hired in long-term care, they might not really know what the symptoms are that they are looking for. They might have difficulty planning care, providing care, and very importantly, documenting care. And as a result, there is symptoms that are not being detected, and there is information that is not passed on, and that obviously has a negative impact on the care for residents in long-term care. One of the main issues that came up in the curriculum review across Canada is that there is almost no knowledge or skill training in conducting geriatric assessments, and there is also no knowledge of the tools that are used for assessments or to report symptoms and signs of long-term care residents. And the one in Ontario, in Canada that we use most often, and in some provinces is mandatory, is the MDS assessment tools. And so many curricula actually do not mention these tools at all. So we really wanted to improve the quality of care for frail seniors in long-term care. And by doing so, we started out by talking to some of these unregulated care providers. And what we discovered very fast is that they really did not have the required knowledge, nor was there any applied training for them once they were in the care field. So with the aim to improve that, we developed our applied, simulated, and integrated learning approach, which we refer to as the ASILA program. And it really is an educational model that aims at improving very targeted outcomes for seniors in long-term care. And the program is designed to be delivered to unregulated care providers. However, in our pilot test, we had 2 nurses participate in this as well, and they had the same satisfaction scores as the unregulated care providers. So we had selected 3 targeted clinical outcomes to be addressed within a applied integrated program, and these clinical areas were focusing on cognitive and physical challenges which unregulated care providers are confronted with on a regular basis. And each one of these modules, and I'll show you one in a bit, includes a demonstration of how to do an assessment and then how to use MDS assessment tools to gather the data or to inform others about what is being observed and then to put the next steps into place. And so one of the discussions that we often encounter in doing some of this work is that unregulated care providers are theoretically not allowed to do any type of assessment in long-term care or home care environments. However, we do rely on them heavily to observe signs and symptoms of chronic disease or any decline that is happening. And so we've chosen the path to teach unregulated care providers some of those assessment skills so they can actually gather the information that is needed to put the next steps in place. So our research questions for this one-year project was really looking at the feasibility of the ASILA program. It was a small study, and we really wanted to make sure that this worked and was feasible before we are expanding it to other clinical areas and to other long-term care settings. Our secondary outcome then, obviously, what it was focused on observing if there was a change in the quality of care for seniors in these long-term care settings, and we looked at these specific outcomes for residents. So the question here was, can ASILA actually raise unregulated care providers' knowledge and confidence in using some of these geriatric assessment tools, and can they actually communicate that information to people that are acting on the next steps then? We used a one-group mixed quantitative and qualitative repeated measures design, and we did this pilot study in 2 long-term care facilities in 2 different provinces, and for each of the facilities we selected 10 unregulated care providers and 3 additional people that were trained to become a trainer in ASILA, and then 20 seniors were selected on the unit that these people worked or on the neighborhood that these people worked. We collected pre and post data immediately following the intervention, the ASILA intervention, and then again 3 months after the ASILA intervention. And our study was approved by the RAB. We obtained individual consent and organizational consent to gather this data. So ASILA basically consists right now of interactive, evidence-informed case scenarios. And we decided to pick on 3 areas that are very frequent chronic diseases in long-term care, and that is heart failure, accelerated functional decline without having any particular underlying reason, and impaired cognition and behaviors. Unregulated care providers indicated that these were 3 areas that they sometimes struggled with, and that indicated they did not have enough knowledge to actually cause a betterment or a change in the situation at hand. So we developed these modules in the form of workbooks for the participants, and each workbook has a video that we take the participants through, and the video explains what the comprehensive geriatric assessment consists of, but it also emphasizes the role of the unregulated care provider in observing some symptoms and how to communicate that to some of the other staff. So there is a strong emphasis on understanding what one's role is in the larger team and finding the right knowledge and description of some of the signs and symptoms that they are detecting. All of the ASILA modules were pilot tested for their effectiveness with 5 unregulated care providers, and we made some small refinements in the way we presented the information. So the ASILA intervention then itself was delivered over the course of 3 days with that training guide and the use of a comprehensive geriatric assessment. And we also used existing MDS tools to gather the information and then the CAPs to facilitate some of the care planning. In addition, we developed a train-the-trainer program for those 3 trainers per facility, and we developed a separate workbook for those trainers so they could take the knowledge that we had taught and then disseminate that to other unregulated care providers in their nursing home. 4 of these train-the-trainers were unregulated care providers and 2 were nurses. So for outcome measures, for the staff, we looked at demographic data and some satisfaction surveys, and then we had some scales that we adapted from the geriatric institutional assessment profile. And so we were particularly interested in geriatric knowledge, in attitudes, in professional issues, in the capacity for collaboration, in the resource availability, and in the values that people put into clinical proficiency and the values people had around assessing, doing assessments in long-term care. For the residents, we also conducted focus groups with the staff. For the residents then, we selected some tools that were collected through the MDS 2.0, and I have them listed there. It's the CPS scale to look at cognition, the ADL scale, a depression scale, the CHEST score, which is a change in health, end-stage disease signs and symptoms, and then a pain scale. And then at a program level, we collected the cost to deliver this or to develop this ASILA program, the cost to deliver it, and then the replacement cost of the staff that were attending the ASILA workshop to see how much it actually would cost to deliver this entire program. So I'm just going to put in a quick 2 slides on INTERI and on MDS 2.0, so people that are not from long-term care environments have an understanding of why this information was so important. So MDS 2.0 is basically a standardized assessment process that is supported by software, and it provides a full picture of the resident. This assessment process is completed when a new resident moves into a long-term care home, and then quarterly throughout the stay of the resident, or it gets repeated when there is a significant change in the resident status. Quite often, these tools or this assessment is completed by the RN or the RPN in the long-term care environment, and unregulated care providers are not really involved in using any of this information. What we often see is that once this information is collected, it kind of stays somewhere in a chart or somewhere in a database, but it's not really used to develop the care planning or to actually look out for changes in a resident status. And we really wanted to have a better look at that to see how could we use all of this information that has been collected already to guide unregulated care providers. So there is also resident assessment protocols once the assessment tool is completed to really guide the care planning for a person in long-term care. And then the software is designed in such a way that it can list some areas that one needs to pay attention to. And the outcome scales that I listed in our outcome measures are scales that really summarize the clinical, cognitive, and functional status of the resident and gives you a good baseline to evaluate and track changes over time. So depending on the case scenario, we embedded a lot of these scales into the learning of the unregulated care providers so they understood what to look for, but it also helped them to understand what we were trying to follow up if somebody, for example, presented with congestive heart failure. And so bringing some of that information together in the workbook and then demonstrating it in the video is really what ASILA was comprised of. So I'm going to show you a video now of one of the scenarios that we played out. This one is the one that looks specifically at a resident with heart failure. And you'll see a resident in the video as well as a nurse and a person and an unregulated care provider. The nurse is dressed in blue. You can see her right there, and she's doing some of the assessment, but she touches with the unregulated care provider to see who is observing for what signs and symptoms. So we're going to cross fingers and hope that all of this will work.
Mrs. Perry? Mary? No, it's the nurse Michelle. How are you, Mrs. Perry? I'm just tired. But every 2 hours I woke up and I just didn't sleep well.
Is there a reason why you woke up so frequently last night?
Well, every time I woke up, I had to go to the bathroom and I had to pee, just a little bit.
Did you have to go to the bathroom that often yesterday?
No.
Is there any discomfort when you pee?
No.
Mrs. Berry, is it difficult for you to breathe in and out?
No.
Do you have any chest tightness?
No.
Would you mind if I listened to your heart and took a look at your legs and your neck? I just want to make sure you're okay.
Sure. Thank you.
No shortness of breath. No chest tightness. Some confusion. Frequent urination at night, possibly due to a urinary problem, but could also be due to the mobilization of leg edema when Mrs. Perry is lying down. Why does she have edema? Well, one important cause can be heart failure. Blood pressure is 135/80, which is on the high side for Mrs. Perry. Pulse of 100 and irregular, and O2 sat of 92%. I can't breathe. Okay, let's get you up.
I'm going to stop it there because I think there is the other part of this is that the unregulated care provider then helps with the nurse to go through the chart and look at some of the information that is there. But so this is a very quick example of how we use this video to look at different aspects of the assessment and then try to identify each team member's role in observing, in this case for shortness of breath or for the inability to lay flat, or maybe there is some signs of confusion. So in delivering these ASILA modules, I want to go over some of our initial findings that we have with this pilot study. So of our unregulated care providers, we had 23 that gave us full data on the demographics, and you'll see there that the demographics are typical for teams working in long-term care. A little bit more than half had a certificate of an unregulated care provider through schooling, and some had the older certificates after high school. There really wasn't any evidence of significant differences between participant teams between the two sites. And so when we looked at this team, we see that we conducted some descriptive statistics and some models to see if there was a change happening over time with the responses we got from the unregulated care providers. And what we see is that there is some changes over time. We see that the raw scores for geriatric nursing knowledge and the use of MDS assessment tools increased in use. And we also see that a rather large improvement, but unfortunately not significant, after after multiple testing for unregulated care providers increase in resource availability. And when we actually asked them about these scores, they indicated that there was a lot more information available that they didn't know was there for them to actually conduct some of their assessments and to report information back. We also see that there is a change in the scores of the perception of care practices. They understood their role better, and they understood why sometimes a nurse or a physician asked to weigh a person or to follow up if a person or a resident had swollen ankles. We had increased staff satisfaction, and we'd also had a bit of an increased perception on the capacity for collaboration. When we look at the satisfaction surveys, there was a strong increase in the perception of unregulated care providers in the role of a team member. So there was a much better understanding on how they contributed to maintaining the well-being of certain residents. Unregulated care providers also felt more confident in providing the care. They were happier with their role on the team, and they felt that their care provided was more resident-centered. There was a few that agreed that the management support was in place, but obviously that could be strengthened. And staff were really divided on the item questioning if the quality of care and the teamwork improved as a result of the ASILA program. And I'll bring that one back up in the discussion. Data from the focus groups then give us some very interesting perceptions on how unregulated care providers perceived their learning. So one of the unregulated care providers stated that I don't think really we ever knew how to actually read them properly, and these are these assessments in MDS. I don't think we were ever shown in school or anything, so that really changed, being able to understand when you're looking at these. Because I would just see a bunch of numbers and try to guess what they mean or whatever, but now we actually know how it works. And two more quotes here. One of the unregulated care providers had the perception that she would save a lot more residents' lives because she was more involved in the assessment and she knew what she was doing. And another personal support worker here stated that she learned a lot about the MDS, really related to what it is that we've seen and what it is that we're doing every day. So these are interesting quotes to see, but of course what we're really interested in is to see if there's a change in the residents' clinical outcomes. And so here on this slide you see the residents' characteristics. I think there is nothing that is really different here compared to other long-term care homes. People are on average 81 years old. They have a mean length of stay, which was 2.5 years. With quite a complex presentation of chronic comorbidities, and there was no significant differences between the two sites. When we looked at the outcome data before and after ASILA, we see that there is a small shift towards increased CPS scores, which puzzled us for a bit because we really wanted to understand why that was. And so we went back in to the sites and we asked questions about how were the assessments completed. And so what we actually discovered is that the two groups of unregulated care providers became very involved in doing the quarterly MDS assessments and had quite different information to be recorded compared to when the nurse was doing it by herself. And so this indicates that there is some changes in these scores. Unregulated care providers also were more able to observe some signs of cognition and impairments in the other modules, and so they brought that knowledge towards doing the quarterly assessment. We saw increased ADL scores, slightly increased ADL scores, and we also saw increased chest scores, which are changes in health and stage disease signs and symptoms of a disease. And so this indicates that there is a more keen awareness of signs and symptoms because of these assessments knowledge transfers. We see slightly decreased pain scores over the 3-month period. I'm sorry. We also, I'm sorry, this keeps going. And then we see also that the depression scores did not appear to change after all. Unfortunately, we had a rather small sample because this was a pilot study, and so our mixed logistic models did not show any non-zero change over time. And so we could not report anything like that. But there is definitely an inclination to think that if we would have a larger sample and we would follow them up for a longer time, that we might see some changes happening in resident outcomes. So I think when we presented ASILA, this is really the first study that targets very specific care deficits in that interactive manner with unregulated care providers. I think quite often there is best practice guidelines and training for the regulated staff. Very seldom do we focus on unregulated care providers, especially not when we add in the documentation and the presentation of some of these signs and symptoms. And we have limited significant changes, but we do see in the interviews that there is a rich description there of what the ASILA did for some of the staff. And in following up now past this study with some of the staff, things have changed that unregulated care providers are more involved in the assessments and are asking us to do more of these scenario developments so they can target different clinical areas. We also see that the data indicates that there is quantifiable improvements, especially in the knowledge area of doing an assessment and in the use of MDS tools. It is interesting to see that unregulated care providers now see a clear link between an assessment and documenting that change and actually improving resident outcomes, where before UCP saw their roles more as providing the daily bath and body care, and everything that went wrong or that was of a medical nature was kind of closed off for them, and that was a nurse or a physician's job to do. We also see that the staff reported an increased confidence of their knowledge, and they also indicated that they perceive to provide stronger resident-centered care. They were divided on the quality of care and how this improved the teamwork. And one of the possible explanations for that is that we only had 10 staff, 10 UCPs per facility, and that number is actually too small to cause a change across the entire team. We had asked facilities to pick their UCPs that they thought would benefit from this ASILA intervention. And so what happened is that both the facilities kind of brought 1 or 2 unregulated care providers from each one of their units. And so only having 1 unregulated care provider or 2 going back with this knowledge to an entire team is not sufficient to actually change some of that teamwork. So we would recommend that it needs to be unit or neighborhood specific to actually cause a change. So in conclusion, this pilot study was not able to show a significant difference in clinical outcomes for residents, probably because of the small sample and the short follow-up period. So we're really interested in moving forward and doing this with a much larger sample and with additional staff. And then we are intrigued by how unregulated care providers are really using these inter-eye instruments now to link them to meaningful change in resident care and outcomes, and that's definitely a second area in which to further do research. So our key deliverables that we have available after the study is that we have these evidence-informed case simulations, and they are being used in both sites. The trainers program was successful in that those trainers have disseminated these informed case simulations to other areas and teams in their long-term care homes. We have these trainers that one of the sites is dispatching these trainers to other long-term care homes in the same organization, because these trainers now have the skills to disseminate this knowledge. We have improved targeted outcomes for frail seniors, but we would like to do more research on that. And we obviously have a variety of knowledge products available. We developed a bit of a learning pedagogical framework on how to best present this information to unregulated care providers, and that we have worked into these workbooks. So it is available with worksheets and questions to understand the knowledge, and then with a practice exam on an MDS tool to see how people would record some of that information. So we feel that just for a one-year pilot program, we were very happy to be able to report some of these key deliverables. So in closing, we strongly feel that the ASILA program has the potential to enhance care for frail seniors. We do see that the staff participating in the ASILA intervention had increased knowledge and confidence. We would like to conduct further work to see how we can change the outcomes for frail seniors. It promotes best practices. ASILA promotes best practices while working within a financial framework of accountability. And the trainer approach was probably the best way to go about this, because it is impossible to have researchers deliver all of these modules, but now that we have the resources available, the trainers can actually do that to their peers, and that is a positive deliverable of this study. So this is a very brief overview of ASILA. I'm happy to open the floor to any questions if you have any available.
Hi,
right
Veronica.
now.
I do have a few questions, and I see some people typing as well. So the first question is, if a team member was unaware of a resident's heart failure condition, how would that affect the resident's care?
Yes, that was actually the first part of the module on heart failure. We really wanted to have UCPs have a good understanding of what heart failure looks like. And so we have a separate video that kind of describes what somebody could look like. So what are some of the signs and the symptoms, and why is it so important to keep an eye on mobility or swelling or edema, or the ability to lay down or inability to lay down, or maybe some confusion during the night or in the morning. And so it was deemed extremely important for these UCPs to understand what a certain diagnosis or syndrome meant, because some of them, or most of them, really didn't understand that if the diagnosis was congestive heart failure, that these were the things that they would see on a daily practice. And so some UCPs actually gave the example that they didn't really understand why for some residents they had to weigh them every day, and for others they had to weigh them every month, and what would the difference be in that case. And so the first part of every workbook is really explaining what is rapid functional decline, or what is heart failure, or what is behaviors caused by a cognition impairment, and then really working through those assessment pieces so they could piece it all together.
Okay.
Did that answer your question?
Yes. Here's a good question. Are there any plans going forward to do this in a multi-center study to demonstrate changes in patient outcomes, or that it is generalizable?
Yes, there are plans to move forward. We are actively seeking funding for that project, because we've put a lot of time and energy in developing the framework, but now that we have that, it is not a lot of work to do that with other topics. What is expensive is the development of the videos, and so we are seeking funding to give us some help with that. But what we are doing right now is we're rolling it out in one large long-term care organization, these 3 scenarios that we have in one large long-term care organization, to collect more data, because as you can see, we only have pilot data from 23 nursing assistants and from a limited number of residents, which is not really sufficient. So we're doing these 3 scenarios in 16 long-term care homes right now, and we are actively seeking funding to expand from 3 to 12 typical scenarios that we see in long-term care.
Okay. There's some very interesting questions coming in, and I'm not sure if you can answer this one, but one of the questions is, are there any legal liabilities from having non-regulated staff involved in assessment?
Yes. So we had, carefully followed the licensing bodies, especially in nursing, around the Delegation Act, and what is it that unregulated care providers can do, and what does it mean if a nurse, an RN or an RPN delegates certain acts to an unregulated care provider. So we discussed that during the work, the ASILA, as well as that for unregulated care providers to truly observe and assess what is going on, they need to have a much better understanding of what is actually happening, what is a diagnosis of heart failure. And so what an RN and an RPN has to sit down with an unregulated care provider and actually go through the chart and say, this so-and-so has congestive heart failure, and this is what it means. Once an unregulated care provider knows the diagnosis, they can actively observe and look for signs and symptoms. And once they have, for example, observed and assessed that this person is not doing well and is maybe has a lot of mobility problems, or maybe has struggles laying flat in their beds because of a lower O2 sat, then they need to inform the RPN, and then they would document with the RPN as a witness some of these observations, signs and observations. But the interesting part that I think this question brings on is that it is an RN's and RPN's is mandate then to respond to these observations, because an unregulated care provider can observe and report, but if a nurse is not responding to those observations, that's where there could be a gap. So we had to really be very careful about who, where, and when do we document some of these things. So as for the assessments for the MDS forums, those assessments were done together between a PSW and an RPN and an RN, depending on who was available, and so that was done in collaboration together. But I have to tell you that just out of interest, we took some MDS forms that were completed on some of the residents, and we took some of these forms to use them during our training of existing residents, and the unregulated care providers were able to detect 4 to 5 errors per form that was already filed. And so it was fascinating for the RNs and RPNs involved in this to see that unregulated care providers probably have a much better understanding of what is happening with the residents at an observational level.
That's interesting. It kind of flows to this question, I think, is how do you account for the variable backgrounds that are likely present in a non-regulated staffing model?
Right. Eventually you have to bring them all up to that same level of understanding and knowledge, and ASILA definitely aims to do that. We had a couple of requests from unregulated care providers if they could sit through another ASILA workshop, repeating the exact same intervention, but a second time around so they could have more targeted questions. So I think for some people it takes a little bit more to bring them up to that knowledge level. We've also seen that in one facility there was a couple of unregulated care providers that leaned more towards the module on heart failure, and they then developed more expertise in that, and then others leaned more towards the rapid functional decline, and they felt more at ease with that knowledge. So I do think people come with different strengths and different interests, and if we can harvest that, that would be great.
Yeah, that would be interesting, because you could do more with that. Here's another very interesting question, is what were the costs associated with this training? Right.
So to make the 3 videos, we worked with Memory Tree, which is a video company that we know quite well, and the 3 videos costed us about $12,000, and then we provided $6,000 to each long-term care organization to have their staff participate in ASILA. The replacement costs, the trainer costs. So the $6,000 is probably more than what a long-term care organization would need to train a group, because we obviously had the research component to it. We had we needed separate times to do a lot of the knowledge, the surveys. We needed separate times to do the focus groups. We needed separate times to select, to get consent. So it was research-wise, you needed about double the amount of time than you would need probably to deliver ASILA. And so without the research components, you can deliver 3 modules in one day, in one 7-hour day to your team. And so if you do deliver ASILA, it doesn't make a really big difference if there is 6 people in the room or there is 25 people in the room. But obviously for this research study, we aimed to only work with 10 people because we were really pilot testing it. So you have to think of the cost to replace your unregulated care providers for a day, and then the cost to develop these modules. Once they are developed, they are available and you can use them in any shape or form that you like. And then there is a small cost associated, of course, with tracking your resident outcomes, which in most organizations is done regardless of an ASILA intervention, but we spent some time going into the data and trying to figure out what was happening.
Okay, so that kind of leads to this question too, is this is a pilot study and there is somebody out in BC asking what it would take to bring the course to them.
Everything is available online. We have the guidebooks available online, and the videos are available online as well. What we are doing right now, or what we're putting the entire guidebook in a bit of a different format, because we've made some changes after the research study to make sure that the content is streamlined. And so we will have those available, and we're actually thinking of conducting workshops for the trainers themselves or for the people that want to do this kind of development within their long-term care organizations. Because if the trainer needs a bit more information than the unregulated care provider, and if there is a workshop that we can put on and just train 10 trainers, that probably would be the best or most efficient way to do something like this. But happy to talk more offline with the person from BC to see what we can share and how we can promote care through unregulated care providers.
Okay, so you might get a lot of calls after this. So I think you have your email maybe at the end of your presentation?
Yes, I do.
So then people are free to reach you that way?
Yeah, absolutely.
Okay, perfect. Okay, I have two more questions probably before we wrap it up. One of the questions is, what is the role of the team in providing resident-centered care?
Yeah, so one aspect of the ASILA intervention that I didn't really highlight here in this presentation is that in our framework to teach unregulated care providers, the last section of each module is really about relating. And with relating, we aim at identifying who is doing what within the provision of resident-centered care. And so we wanted to make it very clear that as an unregulated care provider, your role caring for a resident with, for example, heart failure would be to observe for this and this and this. And then with that knowledge, you would have to go to so-and-so, and these are the kind of information that you would give. And so we work through the entire team to provide the unregulated care provider with the information needed and the language needed to inform the others. And so obviously some of it might have an urgency factor to it. Other things are just an informed and share. Other things can be documented but don't need to really be discussed in person. And so the entire last part of each of these modules talks about what is every team member doing to make sure that this resident is doing well. And so that's the result of that you see coming up in the satisfaction surveys, where UCPs have a better understanding of their role on the larger team, because quite often they perceive themselves as the ones that provide ADL care, and they don't always understand that they also have a role to play in looking for certain components. Now, the other side of the story, of course, is that you have to have RNs and RPNs and OTs and PTs within that team that are also willing to share some of the information. It doesn't do any good if your heart failure resident is put on a different medication or a different dose of Lasix and you forget to tell the UCP. And so the UCP might be weighing the person or might be providing care and would not know that things have changed. And although the unregulated care provider would not have to know all the details of the medication administration, but that UCP needs to know that things have changed for this person in regards to fluid intake and output. And so it takes both sides to do that. We have focused on the unregulated care provider for ASILA, but the nurses that did attend ASILA thought it was very, very useful for them as well. And we've received a couple of requests if we could do this more from a team perspective as opposed to a UCP perspective.
Okay. Interesting. Okay. I might have two more questions for you. Do you see any potential resistance from an HR perspective in that this may seem to be additional duty for non-regulated staff? In follow-up, do you see a potential risk of it being that the nursing home will reduce staffing of RNs and RPNs?
No to both questions, but that's my perception. I work as an RN in long-term care, and so I have found that providing knowledge situates every team member in a better position to do a good job giving care and promoting well-being to residents. And I think it's important to realize that at the end of the day, all of us work in long-term care because we want to do the best we can for these seniors. And unfortunately, unregulated care providers at times are have been on the receiving end of a lot of delegation and orders to do certain things, but we have not really tapped into the potential that UCPs have to really contribute in a very positive way to some of the bigger care decisions that are being made. If I and I now speak just from my perspective, not from my entire research team perspective, but UCPs are 80% or up to 80% in any long-term care home. If we truly want to improve the quality of care delivered, we have to start working with UCPs, because most of them that I've worked with in my career have great potential to contribute to the care, and I think we are not always tapping into that. From an HR perspective or from a replacement perspective, obviously as an RN, I am a strong supporter of having RNs and RPNs in long-term care. I think it's a must, because a UCP obviously can observe those signs and symptoms that need to be observed, but at the end of the day, it will require an RN to bring all of those pieces together, and then to actually, together with a physician, determine on what is the best course of action, and then follow up and implement the best course of action and follow up on that. And a UCP needs a strong leader like that. But we are in this together. It's not, I think, just a nurse's role to do the medical part or the clinical part, and a UCP's role to do the ADL care. These things go hand in hand, especially if seniors are complex and suffer from a variety of different chronic diseases. It's really tricky to bring all of it together. And if given the chance, UCPs could have a very valuable contribution to make.
Your answer makes total sense, because you are having a stronger, more informed team delivering better care. But sometimes it's just the perception that when you get onto something that's new and different, that people fear it. Yeah. Okay, so I think I have one final question. Why is ongoing assessment and monitoring important for frail seniors with complex care needs?
Well, as with any frail senior in a long-term care environment, is that things kind of slowly decline, but at times there are certain situations, and the three that we have picked are the ones that have more of an acute presentation. So there are certain situations that suddenly can happen in which there is a rapid decline because of a specific reason. Maybe because there is an acceleration of heart failure or an exacerbation of heart failure, or the person with personal expressions, because of their dementia, suddenly something is off and there is a lot of challenges trying to provide care to these people. And so although we know that there is a chronic decline for most of these people in our environment, there is very specific observations that can be made to prevent a rapid decline. In most cases, we're not going to prevent the chronic decline, but there is certain things that we can actually do something about that, and that's why assessment is important. And so in using the MDS, if we have all of those baseline measures and we kind of keep track of what is happening, sometimes it really pops up that somebody is in a lot more pain now compared to when they first came into long-term care, or somebody is really having a lot of presentations and signs and symptoms of depression. And so following the trajectory of some of these people is really important, because we can prevent an emergency department admission, or we can actually put the right measures in place to inform the family about what is happening, or to put some comfort measures in place. And so those are all very important aspects of what nurses and UCPs and physicians are doing in long-term care. And most of that is quite predictable. But one has to have the right information to share with others, and so that's why this ongoing assessment is very important.
Yeah, again, that makes total sense too, and I think that's all the time we have for questions today, so thank you for answering all of them, and I'll turn it over to you, John, to close.
So thank you, Veronique. That was great, and certainly I think leveraging the potential of every member of the healthcare team is a way forward if we're going to meet the challenges of caring for an increasing number of elderly patients or people who have multiple functional limitations. So thank you again. That is very interesting, and look forward to hearing about future work on this area. Just to finish off, there's a webinar satisfaction survey that will pop up on your screen within a few seconds after finishing the webinar. Please take some time to provide us with some feedback on how we can improve the webinar series. We do take feedback very seriously, and we do use it to inform the conduct of future webinars. So thank you in advance for completing the webinar satisfaction survey. So just to finish up, we have a few upcoming webinars. We have one on Wednesday, April 6th, again at 12 noon. All our webinars are at 12 noon. And this one is on benchmarking end-of-life care practices for elderly in primary care. This is the results of a CFN-funded core grant by Francis Lowy University of Victoria. We have one 2 weeks later on April 20th on the evaluation of a clinician electronic tool for acute care quality of life assessments of older adults. This is a knowledge synthesis grant and will be presented by Richard Sawatsky of Trinity Western University. And we have one on May 4th, also at 12 noon, which looks at frailty measures for persons with intellectual developmental disabilities. And this is also a knowledge synthesis grant. It will be presented by Elaine Ouellette-Kuntz from Queen University. And finally, as I said before, all our slides, all the webinar slides are available on our website. The web address is at the bottom of the screen. So thank you again for coming online. Thank you to our presenters, and look forward to hosting you on our next webinar on April 6th at 12 noon. And with that, we'll close the webinar. Thank you.